Casey Azuero is a board-certified rehab psychologist and an associate professor in PM&R, and one of her roles is serving as the attending psychologist on the spinal cord unit at Spain Rehab Center.
Thank you, Jenny. I'm going to start by talking about the work we've done with spinal cord injury, and then Jamie will follow suit in talking about the TBI efforts. And hopefully at the end of our discussion today, you guys will have at least an increased awareness and understanding of the initiatives that we have going on across our care continuum, as well as maybe for your own interests, the ability to demonstrate some strategies in engaging multidisciplinary professionals across large academic hospitals like we have here to create sustainable quality improvement projects overall. So when I started in 2016 on the SCI service here at Spain Rehab, I started joining the SCI team meetings that were in place before I started, and definitely heard a lot of ongoing discussion that I don't think started with me in my time here, just talking about kind of the issues that we see on this side of the street when it comes to secondary complications that come from spinal cord injury, and how that really adverse affects our patients' ability to participate in therapy. And over time, I saw several residents do QI projects over here, but those kind of graduated with them when they left, and but the conversations remained, and so we started to talk more strategically as a team about how we can start to make some change, some real lasting change when it came to these secondary complications. And so the goal overall was to bridge the care gap, was really where we felt like we could do a better job. And so, even though it's just across the street physically, I mean, it might as well be worlds apart sometimes, it feels like. So our first step that we sort of came up with was to understand the factors leading to poor outcomes for patients with spinal cord injury overall, and gather key stakeholders and complete some qualitative and quantitative data collection and analysis to understand and define the problem. And then hopefully we would be able to build on that by creating something that was sustainable and really optimized a standard of care with shared responsibility to improve the continuum of care for patients with SCI throughout the health system, and be able to hopefully pilot, tweak, and launch something that would be able to be utilized across the hospital-wide system that decreases the secondary outcomes, but also improves communication with acute care and rehab and with patients and families. So, when you start to get vocal and speak up with ideas, you better be ready to take the lead on some of those ideas. But I in no way did any of this alone. So just within our SCI team, we have Jenny Agricola, who just as a human being has a heart of gold, over 10 years of inpatient SCI experience, and overall a can-do spirit. So really being able to identify where our gifts and talents were and organizing around that, give that woman people to meet, a meeting to plan, and continuing ongoing movement, and she will make it happen. But she said, I'm totally intimidated by data. That's okay. I got this, and I can handle that part. We had an experienced Dr. Kirksey, right? Experienced SCI physiatrist, but overcommitted and not willing to kind of take the lead, but absolutely on board for championing the medical components of whatever would be needed. I was new faculty, so I had time. So I was not overcommitted at that point and willing to take on the commitment. We also had at that time on our team a physical therapist who had previous experience in acute care and inner workings of that, Vanessa, who was integral, and Katie Blackburn with her neurospecialty and PT, and always and persists a strong desire to be able to maximize her time with patients. So, we also had Phil Clevine, an education specialist. So just within our team, we knew we had a great start to being able to at least be able on our end to utilize our gifts and talents and trying to move things forward. So the first step, as I said, was to quantify the problem. So, it wasn't enough to say, this is what I see, or this is what I think, right? We really needed to understand more. And so utilizing the low-hanging fruit of what we had available to us, the electronic medical record and the regulatory tracking system that Chalfé was using at that time for rehab, we were able to determine that nearly 30% of missed visits on our side in acute rehab were related to bowel and bladder. And if you add in just the general medical complications that people were also using as a bucket for nausea and constipation that were coming from bowel issues, that made up about 68% of missed therapy time. We also were able to determine that 2% of patients were coming to rehab with an NSCI, or at that time it was had not fully transitioned, so it was UAB-SCIMS prior to admission to acute rehab, and utilizing the EMR, which was not great at that time. There's been some improvements, but this was in 2018, and we were able to determine that 19% of patients had documented wounds. Also looking at data that compared our site to published SCI model system data, we were able to determine that our average length of stay at UAB at the time was 15 days compared to other model system sites, which was 37. And our average FIM score was 18 compared to 29.7 from other sites. And then we also did our own data collection. So that was all retrospective. We did one prospective study where we went over and with multiple choice asked patients what their diagnoses were in acute care, and basically pretty close to a flip of a coin, we had patients be cord to identify that they had spinal cord injury during their acute care admission. So the next step were partnerships. One of the things that Jenny was able to determine was that through different connections and conversations, the hospital had or has a quality improvement unit. And so we met with them as kind of our first step. And again, just that meeting and on every single interaction we had with people was nothing but positivity and definitely seeing the need and a desire to partner. So they agreed to take on the project, the quality improvement project within their unit. We felt like that was an important step in trying to create some non-bias, more objective experiences, so that when we did start reaching across the street, there was not a sense of us versus them, which we were trying to be very cautious and mindful about. So they assessed processes. They actually followed patients from the ER all the way through the hospital system. They conducted interviews with people to see kind of what their opinions were in general about rehab and patients with spinal cord injury. Ultimately, what they found through their assessment is that there's a lack of continuity of patient education and standardization in that way, and no standardized process to initiate that education, that patient and staff knowledge, and that patient and staff knowledge was lacking, and understanding SCI overall, including pressure injury prevention, bowel management, bowel and bladder management, and the rehabilitation process overall. We also want to be mindful that everybody is busy, and asking others to add anything to their plate is a big ask. And so in addition to having those initial meetings when we did start reaching across the street led by the QI team, and we were, participants in the discussion, we also were very careful to offer what we have done and are planning to do, so that didn't hopefully feel like we were just coming in saying, you guys are doing something bad or wrong, which they weren't, and fix it, So we talked about the changes that we had already made to our education program in terms of the notebooks, the timing of our classes on the unit. At that time, we were going through the hiring and restructuring here at Spain Rehab, but also with the consultation team. A continuum of care was being started. Hence our collaboration with Jamie Wade came into effect. So that it wasn't even just, pre-acute rehab. Also, there were efforts being done for post-rehab continuum of care efforts as well. And creating shared governance in what we were going to do. So universally, again, everyone we spoke to agreed that this is important. Neuroservice and trauma service in particular, they were both on board. But we really wanted to keep things manageable and small, again, with that effort to be able to tweak things real time, have targeted conversations with people so that we could really get something that was workable, manageable, regardless of where it was utilized in the hospital. And looking at the data, 32% of patients come into Spain Rehab were coming from neurosurgery, and trauma made up 27%. So, and they, like I said, they were both on board. We ultimately chose to pilot in trauma because they had the largest number of traumatic spinal cord injury patients coming to acute rehab. And through a connection Jamie helped make when we met with Kelly Flood, she informed us that they were already a designated virtual ACE unit, which is the acute care for the elderly program that she helped initiate here at UAB that has grown bigger than just UAB. But that meant that they already had a mission and a purpose towards managing bowel, bladder, and mobility. We just needed to help them understand how to do what they were already doing, just with a different population. And so who did we want? We wanted everybody, medical providers, the physicians, APPs, nurses, social work, education specialists, all the consultants, so the walk-in, the PM&R, the therapy teams, as well. It was really important. Crystal Gersh was our IT person at the time, our EMR specialist, and having her on board for these discussions also proved really helpful because she was really able to tell us what was possible or not as we move forward in planning. So we figured out the who, we figured out the where, and then we had to figure out the what. And this is just a timeline just to show you guys, we had a lot of meetings. This is before the launch. But in any relationships and building relationships, important in particular, communication is key. And so we held focused small group meetings and learned interdisciplinary larger meetings to facilitate brainstorming and feasibility. Again, nobody wants an extra meeting, and so we really tried to be thoughtful in what our agenda was, and not just sending broad invites, but really being targeted to make sure that we were capitalizing on utilizing everybody's time efficiently too. All again with the start of every meeting and session together focused on our shared goals that we created together as a foundation for where we would always start, and the shared governance that we had. The larger groups were helpful in kind of check-in and to be kind of interdisciplinary. And that was really highlighted to me early on when we were still in the brainstorming session, and there was some kind of rumbling in the back of one of the West Pavilion conference rooms. And so, I opened it up, what's going on. And it actually took Tarina, our nurse manager in SCI, to be the voice for the acute care nurses. They were managers. They were kind of talking amongst themselves. And she said, because we had this great idea, feed them and they will come. We'll just bring food and we'll educate everybody all together at shift change. It'll be great. But it turns out that's not what nursing wanted at all. And that was crucial. And so Tarina just saying, are you guys concerned? Because I think I would be, that now that we no longer have dedicated nurse education time outside of meeting time, that this is going to take people off the floor and this is going to affect patient care. And then that just opened them to say yes. So having those disciplines, even from across the aisle, created a camaraderie and same speak that really facilitated open, honest communication that ultimately went into what we came up with, which was a standardized, or is a standardized power plan to initiate a new standard of care for patients with suspected spinal cord injury, housed within our existing electronic medical record. And so within that, the INSCI exam is automatically checked, as is the physiatrist for medical management to come on board as part of the team and helping truly manage SCI care. Other options as things progress are sitting schedule orders. Sorry if that siren is coming through for you all. Bowel and bladder orders, and directive for wound care, and a change in the medical record system for routine skin checks that nursing can document. Again, people did not want to be fed and educated at shift change. So we created 7 educational modules that live on HealthStream that could automatically be pushed out to anyone to complete. So as there are changes and staffing and things like that can be assigned. But that actually ended up going out to our nurses and at Spain Rehab and Spain Rehab therapists, as well as acute care teams across the board in trauma. It includes a pre-post test, so we could ensure that the messages that we were trying to get across were there. And they are each discrete, so that nurses and people that are busy working could come and go, with each module being no more than 10 minutes. And we've made some tweaks to those based on feedback that we got as well. Our acute physical therapist, Ashton, was able to acquire a Tilton Space wheelchair that was donated. And over time, we figured out a signage to encourage caregiver support in the sitting schedule by tracking pressure reliefs, as well as communication between therapists and nursing, everybody having ability to have ownership on managing those pressure reliefs to implement the sitting schedule was critical, and a tweak that happened along the way. So we piloted for 6 months, again, with routine meetings along the way, just checking in, how are things going, what can we change, what do we need to tweak, those things. And over that 6-month time, the skip, which we marketed just to help kind of keep it and make it snappy, don't skip the skip, was used 58 times. Actually, within trauma, word got out and other people used it, but 20 times in TBNU, 18 times in ATCU, and 12 times in TBICU. And like I said, some other units found out about it and launched it. But overall, in terms of our pre-skip, post-skip assessment, we were able to determine that the INSCI assessment was completion in acute care improved from 2% of patients to 100%. Again, that's the neurologic exam that's used for education and prognosis, and whether they come to Spain Rehab or not, right? Equipment that needs. Improved patient understanding of their illness. Essentially, again, remember that flip of a coin, 100% when we went back post a pilot, or during the pilot, when post-skip launch, 100% of people knew that they had a spinal cord injury in acute care. We had a decrease in missed therapy units in acute rehab from 29 to 14% for bowel and bladder issues, and less than 1% of the time was therapy missed for skin-related issues after the skip was utilized. So, as with all things, we learned a lot along the way, and some of those challenges were, equipment. So we needed equipment to really be able to do this well, and acquisition and ownership of that were definitely challenges. As you all know, here at UAB, space is always an issue, whether it's our clinic space, our office space, our parking space, or storage space. So, that is an ongoing issue that we all face, and that was not unique to this, but definitely an issue. education. So what do you do when people turn over or, or maybe just forget? So being able to figure out ways to overcome that was an initial challenge that we were able to work through, like I said, using the health stream system that we already have in place here. And staffing. So we started in September of 2019 strategically because Dr. Renfro was going to be coming back after fellowship for consultation for our consultation service. And so 6 months from then was March 2020. So we all know what happened March 2020. So with the times of COVID, that completely changed our whole physical therapy structure in acute care, just trying to manage COVID patients, our financial health of the hospital in 2020 was questionable at best. And obviously a mass exodus that happened from the hospital. And so turnover overall is an issue. One of those was that Dr. Kirksey left as well. And so again, even when things started lightening up and we were starting to get back to some more normalcy post-COVID, Dr. Renfro's been working two jobs basically. And so asking her to do anything else, even though we know and she's on board, knowing that the skip is helpful for patients, we couldn't put more burden on an already a taxed team. So there's your plan, right? And then there's reality. And we definitely had a lot of ups and downs in our reality. And so, but honestly, again, meaning making, right? You can only get through the rearview mirror. We needed this time to have the hospital, for Jamie to be able to go to leadership, have the hospital approve the purchase of chairs and cushions so that the sitting schedule could properly be implemented, which she now has and has approval for the funds. Dr. Renfro is working with Amanda Chambers to determine exactly where those chairs will live, but we have leadership support that those chairs will have a place to reside when they arrive. Dr. Twist is now with us. And so having her on board just alleviates that pressure on our physiatry system with that shared governance. And we still have for those MSCI exams, we have worked out the communication system between Dr. Renfro and the therapist that we trained and certified to do those MSCI exams. So I'm hopeful, Jamie, that January 2023 might be our new target for having those chairs here and us being able to kind of get through the holidays and all of that, and perhaps start 2023 with this new with this new initiative going to a larger audience within the hospital. So overall, some of the take-home message that I hope that you all hear from this is that engaging key stakeholders, creating buy-in, recognizing team talents, and implementing a multi-level intervention across care sites, especially at a large academic hospital, it is feasible and it can improve patient outcomes. I will say it requires a champion to lead the charge. There was one time I remember distinctly grabbing Dr. Kirksey in the hallway to follow up with her on some part of the medical management plan of this. And she just looked at me and said, "You really don't give up, do you?" And I really don't. And, I think it takes that kind of dedication though. And obviously that is not just true for me, that fire burns within our whole care team and SCI, and truly everybody we interacted with who cares for people with SCI. So, but I always say that P and PhD There's no I or S for intellect or smarts. I think that P stands for perseverance, and that's just that stick-to-itness that you're willing to work through those ups and downs to get to a final outcome. I also think that this type of initiative takes a lot of effort to engage stakeholders. You guys saw all those, meetings and creating that shared vision and train enough people to decrease the burden and ensure a care plan can be carried out effectively. So the human resources, as well as specialized equipment, can be costly to an institution. So you need leadership and administrative buy-in too. And fortunately, we had that. So hospital leadership, at that time, from the top down, Dr. Ferdinand, Jordan DeMoss, Jeanette Ray, Kelly Flood, were integral. And as Jamie, would go to them, give them updates, talk to them, communicate our needs to be successful. When she would come back to you and say how positive her experiences were with leadership too, and having their support. Obviously, our rehabilitation teams, Crystal Gersh, Denise Graham, Phil Kleba, and Jamie Wade, the entire SEI care team were critical, and acute care teams as well. So to quote Dr. Cox, something like this, it's going to take a culture change, and it really did, and it really had. But their support, Dr. Reef, Dr. Gelbard, trauma nursing, the walk-in team, the quality improvement team, who I mentioned, Nigel Brown, and especially Priya Gulab and others, and acute care therapy as well. So Val, Ashton, and Megan. It really does take a village to do something like this, but it's been an amazing group of people to work with. And it was even more wonderful to hear from Jamie that through this experience, there was growth and a plan to be able to do something similar across diagnoses.